Hello, dear friends and colleagues. I welcome all of you to another video in critical care medicine, which is highly rated, highly popular, and most desired among all the intensivists, critical care physicians, cardiologists, surgeons, everybody, all clinicians. So, first of all, you should know that there are three important views through which we can look at the abdomen: transverse plane and longitudinal plane. So there are two important planes. And further, in longitudinal plane, there are two views, coronal view and the sagittal view. The coronal view is anteroposterior. Okay, it cuts the body into anterior and the posterior half. And then there is a coronal plane or coronal view, which cuts the body into the medial and the lateral part, like this. So this is the coronal view, anteroposterior view of the organs. So you can see the cut section longitudinally, but in the coronal view, you can see whole spine, kidneys, liver, and spleen, the same plane, and both lungs. But in the sagittal view, what you see is the lateral kind of lateral view or sagittal view, which cuts the body into the two halves, right and left. So that is your sagittal view. What we commonly see on the CT plates or CT films are the axial view. So this is the axial view, which is more commonly seen on the CT films. Okay. And if you combine all three views, it is possible. And that can give you the 3D images or three-dimensional images. So to understand the shape, size, extent of each abdominal structure, the relationships between them, we will go through normal axial scans of abdomen. So this is the scout view on the left side corner of this slide, CT scout or scout film, which is a topogram printed on the upper left corner of any CT film, which shows a two-dimensional X-ray image acquired using a CT scanner. Okay, so this is your scout image, right? Remember in a CT room or remember in a CT abdomen, scanning starts from lower part of the chest and it cuts through all the abdominal cavity till the last part of the pelvis. Usually pelvic cavity is covered in the abdominal CT. So here it is an actual view, okay, or transverse view. And anteriorly you can see the sternum, okay, and posteriorly you can see the vertebra. This is the thoracic vertebra. And laterally inside you can see the black structure, which is nothing but the lung. Lung is usually black due to air in it. And in the mediastinum you can see the heart. This is the heart cut, okay, cross section of the heart, transverse section of the heart, okay. And around this rib, this is the rib cage or the bony part of the rib cage. And also you can see outside there are muscles, and outer to which there is fat, subcutaneous fat. You can see the darker one, and the outermost layer here you can see this is the skin. Okay, so this is the typical axial view of the abdomen at the thoracic level. Now we will, so this is your anterior, posterior, left and right. Conventionally, the patient's head in the CT scan and the leg is towards you. You are looking at a patient from the leg end. So that is how it will be. Right will be on this side and left will be on this side. Okay. Anteriorly, you can see this is the anterior. These are the anterior structures and these are the posterior structures. So like that, conventionally, we orient ourselves towards all the cuts in the CT scan. Now observe this and tell me what do you see here. So here you see the outermost structure, which I have told you, the skin and subcutaneous fat and then muscles. You can see all the muscles. These are the paravertebral muscles, and then you can see few muscles in between. In the chest, these are the thoracic muscles, and anteriorly also around the sternum you can see few muscles. So these are the muscles, and inside you can see the viscera. So here this is the lung, black thing, and heart in the middle. So usually if you look at the heart, which is anteriorly placed just behind the sternum, little bit towards the left side. Now look at the RV. This is your triangular shaped RV. RV is usually superficial and anteriorly placed compared to the left ventricle, which is posterior to the RV. Connected to the right ventricle, here you can see the right atrium. Okay, and just nearby the deepermost structure, or you can say the posterior most structure near the esophagus and the aorta, you can see the LA or left atrium. The left atrium is closely related to esophagus and the aorta. So this is your aorta. And then you can see few white structure inside the lung parenchyma, and these are nothing but the pulmonary vessels or pulmonary arteries. Now, as I told you, this is your esophagus, which is between the left atrium and the aorta. And how can you be sure about that this is esophagus? Usually there is air inside. And if the patient is critically ill, usually patient will be having rice tube, which you could observe here as a bright structure inside the esophagus. Okay. So this is your esophagus. And behind the esophagus, you can see the bright structure, which is nothing but aorta. So this is your aorta. It is quite round compared to IVC. It is quite round. Here you won't be able to see the IVC. So IVC will be coming from the RA. Okay, this is your RA. I think later I would show you. And this is the lung window. So if you want to visualize the lung structures, you have to select the lung window on the CT scanner or software, which will be used to examine various pathologies involving the lung basis. This is the basal part of the lung. So obviously you would be able to see the atelectasis, which is nothing but a collapsed lung due to a prolonged recumbency in the critical patients. And also you would be able to see some consolidation or infection or pneumonia. And sometimes you can see the aspirated material inside. And also you can appreciate nodules in forms, especially where you are suspecting the fungal infections. So outer layer of the lung, you can see, it is a pleura. So various pleural pathologies may be observed outside the lung border, like effusions, thickening, plaques, and nodules. The effusion will be located here in the posterior most side. Now, can you appreciate there is structure, one more structure, which is appearing in this cut, and this is nothing but liver. Okay, from this view onward, downward, you will start noticing liver on the right side, and later you will be able to appreciate the spleen on the left side. So here you can examine the liver, okay, and you can see IVC. As I told you, IVC is coming from RA. So very beautifully you can see IVC is usually triangular compared to the aorta. Appreciate the variation or the difference in the shape of IVC and aorta. So here IVC is just posterior to the liver, okay, and towards the left side. So this is what is the relationship between the liver and IVC. And to the IVC, there will be tributaries, which are nothing but the hepatic veins. Okay, so these are the hepatic veins and IVC confluence. Hepatic veins are coming from the liver. Okay, now look at the left side. Now here, spleen is appearing, which is isodense compared to liver. You can appreciate here. So this is your spleen. And just anterior to spleen, another structure is appearing, you can see, which is containing some fluid inside, and that is your fundus of stomach. Okay, this part is appearing here. Now you look at the fundus, gastric fundus, and now look at the esophagus also. In this view, the fundus is bigger and also spleen is bigger. Even liver is also appearing bigger. Now here, esophagus is going to meet the fundus, and in this situation, in this view, you can see gastroesophageal junction. This is GE junction. Okay, very beautifully seen. And from this view downward, you can see the body of the stomach. So this is your body of the stomach. And now you can appreciate posteriorly there is a diaphragm crura. The diaphragm should be studied always in a patient who is having some trauma, okay, or in pediatric patient for herniations and all. The most common site of the rupture, in trauma patients is the posterolateral aspect of the hemidiaphragm. So usually posterolateral aspect of the hemidiaphragm is ruptured, and there is a collar sign sometimes you can see, okay, or the hourglass sign, especially in the coronal view, where you can see the herniation of the viscera through this diaphragmatic aperture into the thoracic cavity, pushing the lumbaces upward, okay, or even the mediastinal structures upward, so that you would be able to see better in the coronal view. Okay, so that's important. Now this is your gastric fundus body both, okay, and you should be able to study this in detail in various views, actual views, scans of CT abdomen, and this should be studied for any thickening, abnormal increased thickening like this. In this sense that you can see the thickening of the stomach wall, and also you should be able to see the enhancement of the contrast material, or sometimes you may see some ulcer, or sometimes you can see some mass arising out of this layer of gastric fundus. Okay, so these are the important pathologies you are going to see in the CT at this level. So appreciate the spleen, which is concave or convex, and it should be always looked for the size. Usually spleen is enlarged in few situations, splenomegaly, and in few situations it may be shrunken. Okay, so in shrunken, like orthosplenectomy cases, in sickle cell anemia and all, you might see the spleen is shrunken. There is no spleen at all. And on the right side, you can see the liver for same thing, for enlargement, enhancement, any mass inside, any fluid inside, okay, any cavity. For those things, you must see the liver. And also the lining of the liver should be examined. This is the smooth line. Can you appreciate? Sometimes this smoothness is gone when the liver is infiltrated by various disorders, okay, especially in cancers. This congruity or the smoothness of the liver border is gone. It becomes rough, and there will be nodules seen. Here you can see this is the cirrhotic liver, where you can see very so many small hyperdense regenerative nodules. Now appreciate here one more structure which is appearing in this cut, and these are the adrenal glands. These are the sleek tissue just anterior to the superior pole of kidney, okay, and usually they are surrounded by the fat. So this is your fat, okay, abdominal fat, and these is the crura of the diaphragm. And so you should, if they are enlarged, suppose patient is having pheochromocytoma or adenoma, in such cases adrenal gland may enlarge. So this is your bile ducts. Can you see the bile ducts here? So these are besides the portal vein. Usually bile ducts are not seen very well. Okay, these are hypodense structures, and they are not very well seen. But in cases of enlargement, you would be able to appreciate them well. Now look at the bases at the hilum of the spleen here. Okay, this is your splenic vein and splenic artery. So this is artery, this is your splenic vein. Sometimes the splenic vein may get thrombosed, okay, which is manifested in patient as abdominal pain and bleeding, GI bleeding, ascites, etc. In the inset, here you can see there is a filling defect, okay, this in the splenic vein, and that is nothing but a thrombus. So usually splenic vein thrombosis may be seen in cases where there is abdominal pain, GI bleeding, and ascites. Now, at this point, look at the branch of aorta which is appearing here, the first branch, which is the celiac trunk arising from aorta, and it's going to divide into hepatic artery and splenic artery. So here you may see the porta hepatis. This is the porta hepatis or hilum of the liver, which contains from posterior to anterior the porta hepatis, portal vein, hepatic arteries, and the hepatic ducts. Okay, and some lymph nodes. In this view, closely you look at the body and tail of the pancreas here, just anterior to the aorta. In the abdominal fat, there is a body and tail of the pancreas, and always examine the size, border, contrast enhancement, any ductal dilatation or fluid. In this inset CT scan, can you see there is peripancreatic fluid collection. This is the pancreas, and you can see there is a collection outside the pancreas, and this is nothing but pancreatic pseudocysts, which are collections of leaked pancreatic fluids. Now observe cystic duct here. Okay, can you see cystic duct, which is going to open in the ampulla of Pater. So later, okay, so here you can see the cystic duct, and here you can see the gastric antrum as well. In the CT view, it should be observed, it should be studied for thickening, enhancement, mass, and ulcer. And remember, from if you just look, trace the CT scan, trace the cystic duct in subsequent CT scans, you will be able to observe the gallbladder. Now here, can you see the cystic duct hyperdense? Okay, this hyperdensity is nothing but it is a stone. Okay, so a stone may be there in cystic duct, should be always observed. And now here you can see the superior mesenteric artery. Now this is the second branch of the aorta. So the superior mesenteric artery is an artery which arises from anterior surface of the abdominal aorta, just inferior to the origin of celiac trunk, and it supplies to the intestine. Okay, it can supply to the intestine from lower part of the duodenum through 2/3 of the transverse colon, and now here you can observe the antrum also, which is opening to the pylorus. Okay, so this is your pylorus, and you can see a wall, that is your pyloric wall. So this is your pylorus, and you can see it is opening into the duodenum. Okay, and sometimes you may see that pylorus is becoming more thickened, okay, more muscular, and which might cause the gastric outlet obstruction. So in cases of gastric outlet obstruction, you would see the pylorus is thickened, and there will be increased, size of the enlargement of the stomach, mega stomach, like that can be seen here. So you can see the pylorus is, the wall of the pylorus is quite thick, and you can see there is a collection. Okay, so whole left side of the abdominal cavity is occupied by the stomach, mostly the fundus and body part, and probably there is a gastric outlet obstruction. Now look at the gallbladder. So can we just go through cystic duct? Yes. So if we go down, so cystic duct is going to open into the gallbladder. So gallbladder should be examined properly in various cuts here. Okay, so gallbladder should be examined for size, wall thickness, and any stone inside, which may be hyperdense. It is important to rule out acalculous cholecystitis as well. Okay, but remember, biliary stones are common cause of acute pancreatitis. The whole biliary system, even cystic duct, should be examined for stone in CT scan. But stones for a stone, ultrasound is better modality compared to CT scan. So stones are better visualized on ultrasound. Now look at the branches of the aorta. Again, there is two more branches arising out of aorta and going into the kidney. These are renal arteries. Okay, So just anterior to the renal artery, even IVC is giving rise to one more branch, which is actually renal vein. Now, left renal vein is usually, you can see this is the left side, this is your right side. Left renal vein is longer than the right renal vein, usually 3 times longer. And contrary to this, if you look at the renal artery, the right renal artery is usually longer than the left renal artery. So these two facts you should remember. Now, renal artery stenosis may also be important to observe. Usually it is a cause of infarction of ipsilateral kidney, and renal vein should be examined for any filling defect, usually thrombosis. So renal vein thrombosis can occur by either a clot or by tumor, and that might lead to congestion and non-enhancement of kidneys. So here you can see the congested kidneys are quite well enhanced. On the right side, left kidney is enlarged and it's not enhanced at all. So that is quite suggestive of renal vein thrombosis. Now, so in the, this is your pancreatic head. Okay, so medial to the pancreatic head, you can observe superior mesenteric vein, and just adjacent to it is the superior mesenteric artery. So if you trace that SMA down, superior mesenteric artery down, you can see that it is going to embed into the mesenteric mesentery, and it will supply to the small bowel. Now observe here both kidneys, okay, which are taken up the contrast quite well and should be examined for morphology, its border, and then you can see inside there, these are medulla. The cortex is outside, which takes the contrast better than the medulla, medullary pyramids, which usually do not take the contrast. And this is normal, okay? If cortex is not enhanced, it is said to be hypoperfusion of the kidney. So observe the kidneys for any enlargement and change in the contour, hydronephrosis, stones, which will be looking as hyperdense. Splenic flexure is visualized here. You can see here. This is the part of colon, splenic flexure. This is the area of the colon which is most sensitive to hypoperfusion and more likely to suffer from ischemia. The sigmoid colon is also very prone to ischemia. And this is your hepatic flexure, which is at the right, which is the right bend of the colon, and which is related superiorly to the liver, and posteriorly the right kidney, and medially to the descending part of the duodenum. Okay, so this is your descending part of the second part of the duodenum, D2. Now here itself you can see just adjacent to the second part of the duodenum, you can see the uncinate process of pancreas. So uncinate process is a hook-like extension from the lower part of the head of pancreas. Okay, and you can appreciate how uncinate process and second part of duodenum, that is D2, and the hepatic flexure are related in this diagram. Now this is your ampulla of Vater. So ampulla of Vater, or the major duodenal papilla, is the point. Okay, so this is very well appreciated here. So this is the point where the dilated junction of pancreatic duct, so this is your pancreatic duct, and a bile duct, okay, enters the duodenum. So that is your ampulla of Vater. Here now you can observe the transverse colon and its rostra fold. You can see, you can observe very well, and then you can also see the hepatic flexure. So it should be observed for the dilatation. Okay, so sometimes transverse colon is hugely dilated, and that situation is called toxic megacolon, which is defined as acute colonic dilatation with a transverse colon diameter of greater than 6 centimeters. So if your diameter is more than 6 centimeters, you can say this patient is suffering with toxic megacolon. So here, in this inset, you can observe. Now, just anterior to the major vessels, you can see the third part of duodenum, which courses transversely from right to left and crossing the midline. So that's your third part of duodenum. And remember, all the posteriorly placed structures lie in the retroperitoneal space. Okay. So major retroperitoneal structures are kidneys, okay, adrenal glands, and psoas major. This is your psoas major muscle, and abdominal aorta, and IVC, and pancreas. Whole pancreas is the retroperitoneal structure, and even third part of duodenum. Okay, hepatic and splenic flexure. This is your hepatic flexure, splenic flexure, which are also the part of retroperitoneal structures, and also the rectum and various lymph nodes. These are all the retroperitoneal structures. So it should be always examined for any lymph node enlargement and any mass or fibrosis or extra fluid. Usually fluid is gravitating or collecting in behind, okay, or in the posterior structures. You would be able to see the fluid here sometimes, especially in the lower part of the abdomen, in the pelvic cavity, etc., in the pouch of Douglas, okay, around the rectum. So there you would be able to see the fluid. And now you can very well see anterior to the retroperitoneal structure, whole peritoneum. Okay, so peritoneal cavity should be observed for any free air. Okay, that is a pneumoperitoneum or collections, or sometimes there may be drain, implant, or sometimes there may be thickening of the peritoneal cavity, or some uh, enhancement may be seen that is suggestive of peritonitis. And sometimes you might see the hernia if your shape of the peritoneum is not proper. This, okay, this is your retroperitoneal fibrosis around the aorta and blood vessels. And the most common symptom of retroperitoneal fibrosis is the pain in the lower back or abdomen, constant chronic pain. Here you can observe the superior mesenteric arteries in the mesentery. So this is your bowels, small bowel, and inside you can see the fat, and then hyperdense structures, which are arteries. So this is whole mesenteric fold of membrane that attaches the intestine to the abdominal wall. Mesenteric tear may occur with the lap belt injuries, okay, that can give rise to hematoma and hemoperitoneum, okay. And in CT, you would be able to appreciate high density blast within the mesenteric root. This is the blast you can see in the mesenteric root, and contrast pooling down in the left posterior abdomen. So in this CT scan, probably you can see very well the bowel wall thickening also, okay, the bowel wall thickening here, which is suggestive of intestinal ischemia due to reduced bowel perfusion because of mesenteric tear. And when there is a mesenteric tear, definitely there will be mesenteric vessels injury and mesenteric vessels rupture in cases of trauma. Now, anterior to the bowel or transverse column, you would be able to see the omentum. Okay, omentum is actually a fat. So this is the greater omentum, which is the largest peritoneal fold, consisting of a double sheet folded upon itself and thus made up of 4 layers. You'll be able to see the omental caking, which is a pathological sign or radiological sign, which is observed on CT scan and can easily be identified as diffuse haziness, okay, and mass-like effect. That is the omental caking. And outside this omental caking, you can appreciate the fluid. Then you see the cytosource. Now, never forget to appreciate the subcutaneous tissue and musculature on CT scan. Muscles are usually hyperdense. These are the muscles, green, and then you can see the fat, that is your subcutaneous fat, which is hypodense compared to muscles. So now we will talk about the psoas major, psoas muscles, which are located in lumbar region of the spine, either side of the vertebral column, okay, and it extends through the pelvis to the femur. So sometimes psoas major or psoas muscles are focus of infection. They may have abscess, okay? And these are one more set of muscles. These are quadratus lumborum. So these muscles usually are in the posterior abdominal wall, and they lie deep inside the abdomen, usually dorsal to the psoas major. So here you can appreciate well. So this is your quadratus lumborum, and this is your psoas major, usually posterior to the psoas. But they are inside the abdominal cavity, especially in the posterior abdomen. They are part of posterior abdominal wall, you can say. And just outside the abdominal cavity, behind, you can see rectus spine, which are the deep muscles of the back, okay? And that strengthens your back, and they can rotate also your back. Now look at the aorta. Aorta is now bifurcating, okay? It is bifurcating into the common iliac arteries, okay? So usually aortic bifurcation occurs at L4 vertebra, L4 level. So remember that the common iliac artery usually arises from aorta at L4 level. So now you can see one more muscles. So muscles found on the lateral side of the abdomen, and they are transversus, abdominis, and oblique muscles, okay? And anteriorly, you can see one more group of muscle, a pair of muscle, that is your rectus abdominis. This is your long muscles of anterior abdominal wall. This is your linea alba. So this is your thin band of connective tissue attaching both the rectus abdominis. Okay. Now on the right side, can you see the cecum here, which is a pouch within the peritoneum and is considered to be the beginning of the large intestine. So this is your ileocecal junction. Can you appreciate one pouch which is connecting, which is insinuating into the cecum, and that's your ileocecal junction, which is the most commonly affected site in tuberculosis, abdominal tuberculosis, and can present with the obstruction, perforation, and sometimes you will be able to see the ileocecal mass, whole mass. You can't differentiate the ileum and appendix and cecum very well with the whole mass. Okay, you can observe the sphincter muscle. Okay, that sphincter is important to regulate the intestinal transit. It acts as a barrier to delay the passage for small bowel content, and hence increases the absorption in the small bowel. So it also prevents the reflux from reflux of the material of fecal matter in the cecum back to the ileum. So that is a valve, okay, ileocecal valve. It has an important function, and sometimes if it is not properly working, it can give rise to a lot of problem, and those problems can be called as ileocecum syndrome. Okay, so this valve may become incompetent, leading to reflux of undigested food back to small bowel, and that can cause small bowel enlargement. Now here you can see around the aorta some common iliac lymph nodes as well, and you can see both iliac arteries here very well. Now look at the descending colon, which is usually fixed structure in the retroperitoneum, and it is a smaller caliber compared to the right ascending colon, okay, or ascending colon. So can you see ascending colon? Can you appreciate the difference between the calibers of ascending colon and the descending colon? Now we will talk about the appendix. Appendix is blinded and blind-ended tube connected to the cecum. Okay, it's very small, thin tube. Usually, it is connected to the cecum, and it's commonly located posterior. Commonly, there may be a variation in position, but retrocecal position is the most common position of the appendix. So if you scroll up and down in the CT scan, you can see its connection with the cecum. So here the cecum, it is connected to cecum posteriorly. Cecum may be swollen in cases of acute appendicitis. Sometimes appendix can have a hard structure, which is usually hyperdense on CT scan, and it is a stony mass of compacted fecal matter. So that is your fecalith. Okay, and now you can see the bifurcation also here in IVC, but which was not there previously. Can you see the bifurcation? I think at this level, there is a bifurcation which is happening. So usually that happens at the L5 level, L5 vertebral level. So IVC bifurcation occurs one segment down compared to aortic bifurcation. Okay, so IVC bifurcation usually occurs one segment down compared to the aortic bifurcation. Now look at the small bowel. Can you see the bowel loops, small bowel loops, which have very good wall enhancement. And inside you can see the fluid, but there is no air in the small bowel. Here in this large bowel, you can see some air, okay, anteriorly. So now look, appreciate the bowel wall enhancement. These are the normal bowel wall. There is no thickening. So it should be always examined for the thickness, okay? And also should be appreciated for the caliber. So if there is a obstruction in the bowel, the small bowel will be dilated. Okay, and also wall thickness is important to be observed. Sometimes it may be thickened in inflammatory and ischemic bowel diseases. Now here, posterior, and at this level, at L5S1, the common iliac arteries divide, okay, to the external and internal iliac arteries, external and internal iliac arteries. And the internal iliac artery supplies the pelvis, pelvic organs, reproductive organs, and the middle part of thigh. Now here you can see one more muscle in the iliac crest. That is your iliacus. Iliacus is a fat triangular muscle, which is pelvic muscle, kind of intrapelvic muscle, and it fits the iliac fossa. So this is your iliac fossa, and it forms the lateral portion of iliopsoas, okay, and provided flexion of the thigh and lower limb at the acetabulo-femoral joint. Now look at posterior muscles just outside the iliac crest. These are the gluteus muscles. Okay, they are attached on the outer surface of the ilium, and this is your sacroiliac joint. So, as I said, iliacus is a flexor of the sacroiliac joint. So sometimes it might be thickened, it might be increased fluid. You can see. At S2 level, internal and external iliac vein join to form common iliac vein on the both sides. You can very well appreciate internal iliac vein and external iliac vein here at this level L5S1. And now you can appreciate the gluteus minimus, medius, and maximus. You can easily make out all the gluteus muscles in this CT scan level with a very good differentiation. And also you can observe few small bowel loops here, and also you can observe the sigmoid colon. Now at this point, you will be able to see the sigmoid colon, which is actually a S-shaped portion of the large intestine that begins in the front of the pelvis, at the front of the pelvis brim. Okay, so this is your pelvic brim. So at this level, it starts and it continues to the descending. It is a continuation of the descending colon and becomes the rectum, okay, at the level of S3 or third sacral vertebra. And there are many different conditions that can cause problems with this sigmoid structure of colon, which include colon polyps and inflammatory bowel disease like ulcerative colitis or Crohn's disease. And also sometimes you might see the cancerous growths and fistula, diverticular diseases. The most importantly, you might see the volvulus, where you would be able to see the constriction at some point and large bowel air, okay? So that is also pathological. So that occurs due to twisting of the colon at this point. And as I said before, the sigmoid colon turn is usually the area where the perfusion is not very good. Now at this point, rectum starts at the level of S3 at the sacral promontory, okay? And that is your continuation of sigmoid colon. And here you can see the piriformis muscles, okay, which lies deeper to the gluteus muscles and originate from anterior surface of the sacrum. And here you can see mesorectum around the rectum. So this is your fascia, which is a layer of connective tissue enclosing the perirectal fat. Okay, this is your mesorectal fat. And that's important anatomical structure in the rectal cancer staging. Now, anteriorly, you can see the urinary bladder. Look at the ureters which are entering behind the urinary bladder. Now, observe few bony structures which are of special interest, like acetabulum. So this is your acetabular cavity, and then you can see inside the acetabular cavity femoral head, and behind you can see the shear spine. Okay. Now observe the rectum closely for thickening of wall or any abnormal mass inside, and between the bladder and rectum you can see the seminal vesicles, which are butterfly structure, long tubular structures. So this is kind of bow tie or butterfly appearance, which is basically a seminal vesicle. And anteriorly, as I said, a bladder which is filled with urine here, and it should be observed for thickness of wall and contrast enhancement, which might be suggestive of cancer, inflammation, and sometimes the filling defect may be observed, which may be suggestive of stones. And now see the bladder side is decreasing as we go down, and there is one more soft tissue structure which is appearing between the bladder and rectum, and that's nothing but the prostate. So prostate is located just below the bladder and in front of rectum. So prostate should be measured for the size, and its contour should be examined, and also sometimes this contour is not smooth, it may be rough in inflammation and cancer. But remember that CT is not a very good modality of imaging to differentiate a cancerous and non-cancerous enlargement of prostate. And now you can see the anal canal last part, which is the part that connects the rectum to the anus, which is the opening, with the last opening. You can see here various pathologies like infection, inflammation, collection in the perianal region. Perianal abscess, for example, perianal abscess. See the perianal abscess in this inset of CT scan. And thank you. I think I have covered whole CT abdomen, including the pelvis and lower part of thorax.